Good
Can I
afternoon,
start?
everyone. Just 2 minutes, ma'am. Good afternoon, everyone. Center of Excellence at Bowring at Lady Curzon Hospital, Bangalore, welcomes all the participants for today's RDLS session. Today's topic is HIV and OI, skin and mucous membranes, and the speaker is Dr. Shweta Sridhar, who is currently working as the assistant professor with the Department of Dermatology at Sri Atal Bihari Vajpayee Medical College and Research Institute, Bangalore. We welcome you, ma'am, for today's session and request you to start the session.
Thank you so much, Shweta ma'am, and thank you, iTech India, for this opportunity. So I am Dr. Shweta Sridhar. I'm currently an assistant professor in Bowring and Lady Curzon Hospital, also known as Sri Atal Bihari Vajpayee Medical College. So today we're talking about HIV and opportunistic infections, mostly of the skin and the mucous membranes. Next slide. Yeah, so this is how we'll go about our session. So first we'll have a quick introduction. Then we will talk about the various manifestations of skin and mucous membrane that happens in HIV patients. That could be bacterial, viral, fungal infections and inflammatory conditions. And then we'll also talk about some of the cutaneous malignancies which are more common in people living with HIV and everything else about that. So what we need to know and what is our major takeaway from this session would be that most of the skin conditions that we see are mostly seen in our OPD on a daily basis. But if if a lesion is very severe or it's recalcitrant to treatment, it is not going and it is chronic and it presents with a more severe form, then we have to suspect HIV. So we will have to get all of these people tested for HIV. So that is why we need to identify these conditions, because not everyone picks up these conditions at the first go. If like, for example, if a patient has candidiasis and if it's a first time, we would still be treating normally. Only if it's recurrent, extensive, that's when we would send for HIV. Yeah, next slide, please. So more than 90% of the people living with HIV develop some kind of a skin or mucous membrane lesion. And usually what happens is the prevalence of the skin manifestations in children living with HIV range from 36 to 52%. So identification of certain skin conditions can predict the presence of HIV. That is what I was talking about. Like some lesions are extremely characteristic of HIV, like oral hairy leukoplakia and extensive herpes zoster, which we would not see in a patient of which is in a patient who is immunocompetent. So when a lesion is persistent and it is recurrent or it is chronic, severe, extremely resistant or atypical, that is when we suspect HIV. And these are what is more common in people living with HIV. Next slide. So this is the spectrum of dermatological manifestations in people living with HIV. We see that as the CD4 count comes down, we see more extensive lesions and lesions which are not extremely common in our skin OPD to be manifested. So usually when the CD4 count is more than 500, we either see an like in the seroconversion stage, we see a exanthematous rash, but extensive tinea corporis or extensive psoriasis, which is resistant to treatment, or seborrheic dermatitis is more common in the early stage. That is where the CD count is more than 500. In the intermediate stage, that is when it is between 200 to 500, we see more lesions of folliculitis, pityriasis versicolor. We see warts. Warts are commonly seen in our skin OPD, but when they're extensive or when they're in the genital area, that is when we have to suspect HIV, or even molluscum contagiosum, which is an extremely common OPD condition. But in a patient with HIV, it presents with extensive lesions which are extremely resistant and it's widespread. So that is when we have to suspect. When the CD4 count falls to below 200, we see more of papillary or follicular eruptions, oral candidiasis, oral hairy leukoplakia, Kaposi sarcoma, and Norwegian or crusted scabies, which is a severe form of scabies. This happens in the advanced stage, maybe 13 years after they present with HIV. Yeah, next. Yeah. So when we classify the skin diseases, we have to classify them into infective, which could be bacterial, viral, fungal, or parasitic, inflammatory like psoriasis, cutaneous malignancies like Kaposi sarcoma, and the miscellaneous conditions. Next slide. So most common amongst all this is the infective conditions. And even in the infectious conditions, fungal infections and fungal, viral, and bacterial infections are the ones which are more commonly seen, especially the viral and the fungal infections. In the bacterial infections, all except bacillary angiomatosis and diseases caused by atypical mycobacteria, the other lesions are something which we commonly see in our OPDs. So, if we see a lesion, if we see a person with folliculitis or furuncle, we would not suspect HIV at the first go. Only if it is severe or recurrent, that is when we have to suspect HIV. So, bacillary angiomatosis is a condition caused by Bartonella henselae, which I'll further talk about, and this is extremely characteristic of HIV. And even the disease is caused by atypical mycobacteria, we will not see in any other condition except this. So coming to the fungal conditions, oral candidiasis is the one which is most commonly seen, but even extensive dermatophytosis, which is extremely recalcitrant to treatment, is seen. The other conditions which we could be seeing is penicilliosis or cryptococcosis or even histoplasmosis. Next slide. So in the viral infections, herpes zoster is extremely common, but when should we suspect HIV in a patient with herpes zoster? When the lesions are extensive, when the lesions are when the bullae are hemorrhagic, or when it is a multidermatomal spread, that is when we have to suspect HIV in a patient with herpes zoster. Oral hairy leukoplakia is also something very characteristic of HIV. Molluscum contagiosum, condyloma acuminata, and verruca are seen in almost all our OPD patients, but with a more severe extent in HIV patients. Coming to the arthropod, the parasitic diseases, scabies is extremely common, but scabies, the crusted form of scabies or the Norwegian scabies, is very common in HIV patients, and something called Demodex folliculitis, which is a normal mite living on our skin, presents with extensive lesions in patients with HIV. Next. Yeah. So coming to the inflammatory cutaneous conditions, we see xerosis because of sometimes even because of the treatment they receive. That is also more xerosis which is not responding to just moisturizers. So we have to prescribe them something else. So and even ichthyosis vulgaris, psoriasis in a more extensive form where there's extensive body involvement is seen. Seborrheic dermatitis is extremely common. Almost all of us have seborrheic dermatitis, but when a patient is not responding to classical treatment and he's extremely symptomatic, that is when we have to get a HIV test done in him. Rhetus syndrome, that is reactive arthritis, is not very commonly seen in our OPD. But if a patient has Rhetus disease and there are some characteristic dermatological manifestations, that is when we will get a HIV test done. Eosinophilic folliculitis is very characteristic of HIV and even atopic dermatitis. Next slide. So what are the other conditions in other cutaneous conditions? Cutaneous malignancies, like I was talking about, Kaposi sarcoma is very common, and non-Hodgkin's lymphoma. Miscellaneous conditions could be drug reactions, pruritic papillary eruptions, extremely common in HIV. These are something which are underrated and misdiagnosed in HIV, but extremely common. And even drug reactions, which are of a severe onset, we have to send them for HIV testing. Next slide. So coming to the infective conditions first, we'll talk about the bacterial infections. That is the conditions caused by Staphylococcus aureus or even Streptococcus. But first is Staphylococcus aureus. Most common is folliculitis. But if we in the center of the slide, we see a deep bacterial infection called ecdyma, which is not extremely common in our OPD, but it could present with a more severe form in people living with HIV. And non-bullous impetigo is very common in children. We all, because of the hygienic conditions in some places, we see that we see honey-colored crusts, especially around the perioral area. But it can present in people living with HIV too, as and the causative organism is Staph aureus. Next slide. So usually how does bullous impetigo presents? It presents with very superficial blisters or erosions that may be polycyclic, and usually they present on the arms, on the trunk. And because usually these blisters are flaccid and they're short-lived, and often only so often we only see these yellow-colored crusts that are present. So how do we treat a patient with bullous impetigo? You have to first counsel them about the hygiene and how they have to maintain their hygiene, and you have to gently clean the lesions with water and soap first. And usually oral therapy is not recommended unless it's severe, but we can give aminopenicillins or cephalosporins depending on the severity. Next slide. So skin abscess or pyomyositis. So this is a more extensive form, and usually they are deep bacterial infections. And these are follicular lesions which extend more deeply, and they form abscesses which make the affected area fluctuant and warm. So they'll be extremely symptomatic. They could have a prodrome of fever also. And rarely all the follicles across several square centimeters are affected. That's why they all coalesce to form a big abscess. And sometimes they can even be misdiagnosed for Kaposis, but it's usually when it's fluctuant warm, we have to think of a pyoderma, that is skin abscess, than a skin tumor. And usually we have to send it to the surgeon for surgical drainage and incision and drainage. And these people have to either be admitted or have to be put on systemic treatment with cephalosporins or amoxicillin clavulanic acid. And if they're in sepsis, we have to consider IV treatment with vancomycin. Next slide. So when we are looking at superficial infections like folliculitis or furunculosis, usually happens around the hair follicles, like on the trunk, groin, axilla, or the face. Carbuncles are deeper infections, and they usually have multiple openings because of the invasion and necrosis of the subcutis. Usually treated topically, but if they're extensive, then we have to give systemic treatment with cephalosporins. Otherwise, topical treatment with mupirocin, fusidic acid, or ozinoxacin should suffice. Next slide. So this is one thing which we can't miss, and it's a sin if we miss bacillary angiomatosis, because more often than not, it is the clinching diagnosis. If we see a patient with bacillary angiomatosis, we have to suspect HIV. So it is caused by the Bartonella, Hensley, or Quintana. And these start with small red papules that gradually expand into large papillar, nodular, and pedunculated lesions. They usually have a vascular appearance, and the surface is friable and bleeds on touch usually. So systemic findings are extremely common. They will have fever, they might have night sweats, they might even present with weight loss. And when there is systemic involvement, that is liver and spleen, it is the most diagnosed form of the visceral disease. And usually we use silver stains to diagnose bacillary angiomatosis, but or sometimes what we can do is we have to take all the universal precautions. We have to do a skin biopsy to find out in where we see dilated capillaries. And because of the appearance, because they'll be presenting with nodules and usually with a vascular appearance, these usually cannot be missed. So we will usually look at it and diagnose with bacillary angiomatosis. So the treatment is erythromycin, either erythromycin 500 mg 4 times a day, or doxycycline can be given. Usually IV therapy for about IV therapy for severe disease like visceral involvement is given, and we continue the therapy for about 2 to 3 months. Azithromycin is uncommonly used, but we can use as an alternatively if they're not responding to the conventional treatment. Next slide, please. So these are the mycobacterial diseases that we are talking. This is caused by cutaneous TB, that is scrofulloderma, and this is extremely common in HIV patients, but because they usually present with pulmonary TB, less common with cutaneous TB. But if they have if they have lymph node TB, that is when it can open up and form scrofulloderma. So we have to check. So in the girl, you can see that opening with oozing of pus. That is when we have to think about scrofulloderma. Next slide, please. So we have what we need to look out for is atypical mycobacteria. That is, if we see this is if we see Mycobacterium avium intracellular, that is MAC complex, which presents as chronic sinuses over the involved lymph nodes, chronic ulcerations. That is more characteristic because we don't see that in a normal OPD basis, but TBVC, that is tuberculosis verruca cutis or scrofulloderma, is common in people who live with HIV because more often than not, they will have pulmonary TB. So you have to give them ATT according to the national guidelines. Next slide, please. Syphilis. Syphilis is more common in HIV infected patients because we see concurrent STDs in a patient who has been infected. So more common in HIV infected patients than in non-HIV infected patients, and usually presents with a painless indurated genital ulcer as the primary chancre. Secondary syphilis presents with usually maculopapular rash, and it presents in palmar and plantar rash, that is called the palmar and the plantar syphilitis. Usually treatment is benzathine penicillin, single dose, but we give 3 doses in patients living with HIV depending on whether it is latent, or early latent or late latent syphilis. Usually patients with living with HIV come with an unknown duration. In those cases, we have to give 3 doses as a precaution. Next slide, please. Next slide, please. Yeah. So these are the skin manifestations. So in primary syphilis, you can see the primary chancre on his shaft of the penis, and this presents as a painless ulcer, but it is indurated, so it cannot be missed. And these are the palmar and the plantar syphilites. So they are extremely classical. They are painless, but if we prick it with a blunt object, like a blunt tip of a pin, that is when we notice that these people will complain of deep tenderness. So this is called a Buschke-Ollendorff sign, and it cannot be missed in syphilis because this is a clinching diagnosis for secondary syphilis. Usually when someone presents with this, we could suspect palmoplantar psoriasis and we could be treating them with that. But if a patient presents with genital and generalized lesions, that is when we have to rule out syphilis. So secondary syphilis is extremely common, misdiagnosed, and we have to check it in a patient with HIV. Next, please. So fungal infections are again very common, and amongst them is candidiasis. So oral candidiasis is extremely common even in patients with diabetes. So that is when, if a patient has diabetes and HIV, we will not get the HIV done because we would think it's because of diabetes. So something which is severe and presents with other manifestations, that is when we get a HIV test done. So it presents as a vivid red, slightly eroded and studded with tiny pustules at the periphery. So these satellite pustules are a pathognomonic characteristic of this disease. Coming to oral candidiasis, it comes with a white membrane, that is a curdy white membrane which covers the tongue, and when it is opened, it reveals the eroded surface. So it can also affect the nails. It can cause chronic paronychia, and this presents with tenderness, erythema, and bogginess of the proximal nail fold. How can we diagnose? By potassium hydroxide or KOH examination of the scales, or we can do a KOH mount and we see something called a pseudo hyphae in this, which is extremely characteristic. So treatment is topical antifungal cream such as clotrimazole or ketoconazole, less often ketoconazole, but fluconazole 100 mg or 3 to 6 mg per kg per day in children once for 10 days is given. OD for 10 days. Next slide, please. So tinea infections again extremely common in our OPD, but if it is it is usually caused by superficial fungus. It's called a superficial fungal infection, and usually the manifestations are tinea cruris, corporis, manum, tinea pedis, tinea capitis, and onychomycosis. In children living with HIV, tinea capitis can present with broken hairs, which results in non-scarring alopecia, scaling, and pustules. So usually in children, tinea capitis is very common, and that leads to sometimes even scarring alopecia called chirion, where it comes with a boggy swelling. So in a patient who comes with a boggy swelling and there's discharge from it with no hair over that lesion, we have to suspect tinea capitis, and it is present mostly in children who present with even prodromic symptoms. They might be having fever. It has to be referred to a dermatologist because they will take care, and they will have to be started on systemic therapy when if warranted. Next slide, please. So the other fungal infections like Pityrosporum ovale and Malassezia furfur, which causes tinea versicolor or seborrheic dermatitis, are common. So Pityrosporum ovale causes seborrheic dermatitis, and it can also cause Pityrosporum folliculitis. Malassezia furfur is the causative organism for pityriasis versicolor. So usually occurs in the seborrheic areas of the skin, that is the center of the chest, center of the back, scalp, flexures, and upper trunk. Usually it's a clinical diagnosis, but sometimes we can do a KOH mount, especially in case of tinea versicolor, where we see something called banana and grapes appearance or spaghetti and meatball appearance, which we see characteristically in pityriasis versicolor. So the treatment usually involves selenium sulfate shampoo or a topical azole cream. Usually we give ketoconazole, or we give oral itraconazole 100 mg BD or 200 mg OD for 1 week if it's extensive. Next slide, please. So deep mycosis more common in HIV. We saw this deep mycosis more common when COVID was there, like we saw mucormycosis. Here it is more where penicilliosis or cryptococcosis, histoplasmosis are more common. Sometimes they can even present with systemic candidiasis or actinomycosis. What is teloromycosis? It has central necrotic papules with umbilication, which occur on the face, trunk, and extremities, which happen maybe 40 to 70% of the patients. Cryptococcal skin lesions are very, very common. They will be infected with cryptococcal meningitis, and they present with lesions on the face, and their cutaneous cryptococcus is a very close DD, differential diagnosis for molluscum contagiosum, which only after we do an India ink preparation, that is when we will see the capsule of the cryptococcus. Next slide, please. So this is how teloromycosis or penicillosis presents. It usually presents with umbilicated nodules on the face trunk. This also can resemble molluscum contagiosum. This second lesion is cryptococcal. Again, how you see how there is a close resemblance to molluscum contagiosum. Histoplasmosis is another, it can present with a maculopapular rash. Next slide, please. So coming to the viral infections, human herpes virus, that is causative organism of Kaposi sarcoma. It is associated with all forms of Kaposi sarcoma, which include classic, endemic, transplant-related, and AIDS-related, as well as rare neoplastic disorders such as primary effusion lymphoma and solid organ variants. And it can also be associated with Castleman's disease. So how does Kaposi sarcoma present? It presents as a non-tender violaceous macule or a nodule. So there'll be a purple colored lesion, and sometimes they can also present with oral lesions, that is purplish fleshy lesion on the roof of the mouth or the gums, or it can present with localized lymphadenopathy. Next slide. So how in skin, coming to the skin lesions, if they are violaceous macular or nodular skin lesions, we have to suspect Kaposi sarcoma. Coming to the oral lesions, we have to think about, it will present with a purplish fleshy swelling on the roof of the mouth or the gums. In pulmonary, it can present with something related to related to pulmonary TB or pneumocystis carinii pneumonia, or even in the internal viscera, it can present with shortness of breath, painless rectal bleeding, or melena. Diagnosis by cytological and immunological markers, not very common in India, though. Next slide, please. So this is rare forms of cutaneous Kaposi sarcoma, where we classically see that hyperpigmented or violaceous on, because in skin of color, that is Indian skin, we may not be able to see the characteristic violaceous color, but hyperpigmentation and nodule type of lesion, which is not responding to treatment, is very common. Next slide, please. So how do we manage Kaposi sarcoma? So the mild to moderate form we have to initiate ART. When there's visceral or disseminated cutaneous involvement, we have to think about, we have to consult the oncologist, and we have to start them on chemotherapy with liposomal doxorubicin, which is preferred for the first line as chemotherapy. And we shouldn't use any corticosteroids in patients with Kaposi sarcoma, because we would be exacerbating some infections if we use a steroid. In primary effusion lymphoma, we have to give chemotherapy, or oral valganciclovir can be given, or IV ganciclovir can be given. In multicentric Castleman's disease, they should receive ART in conjunction with IV ganciclovir or high-dose zidovudine or rituximab. Prednisolone is again plus or minus, depending on the risk to benefit ratio. Next slide, please. So in patients with herpes simplex, as we know, very common in our OPD, but more than 95% of the homosexual men have a history of HSV. We have seen this even in our OPDs, and usually HSV shedding occurs when the CD4 count falls to less than 200, and a significant cause of proctitis in men with HIV patients who have, that is men who have sex with men. This is a major source of proctitis, and especially because they usually they usually have intercourse without protection. And the manifestations of the non-mucosal HSV infections, that is HSV keratitis, HSV encephalitis, or herpetic whitlow, are like those in normal HIV seronegative also, but it is more common in patients with HIV. Next patient, next slide. Yeah. So, what are the phases of the course? Usually, primary infection, the host acquires the infection for the first time. Latent, where the virus remains in the host as an inactive form, so it's not causing any active disease. Reactivation happens when the host's immune system is impaired. Next slide, please. So, what are the clinical manifestations that we could present with? HSV1 presents with orolabial herpes, and HSV2 presents with genital herpes. So orolabial herpes usually presents as herpes labialis, where it involves the lip and the oral mucosa, and it will form a vesicle, sometimes even a papule could be seen, and that forms into an ulcer, and finally it crusts. So usually progresses rapidly, but it could be extensive if the CD4 count of the patient is low. Genital herpes is extremely common in HIV, and usually happens as a concurrent sexually transmitted infection in these people. Usually happens as vesicles, but we will be seeing in the genital ulcer disease, because the vesicles would have burst. It's an extremely painful condition, and there'll be tender inguinal lymphadenopathy as well. Next slide, please. So this is how in a child there'll be orolabial herpes. So you can even see the unusual presentation of pustule in them. Normally, we don't see pustule. Only in such patients, in people with HIV, we would be seeing a pustular presentation as well. And genital herpes we can see in this slide on the penis, shaft of the penis. Sorry, next slide. So diagnosis happens either by PCR or viral culture, but again, sometimes we do a Zang smear, or mostly the diagnosis is clinical. We cannot miss herpes. Only in confusion, maybe we do a Zang smear. So management of the orolabial conditions, where we give acyclovir 400 mg 3 times a day for about 7 days in a primary lesion, 10 days in recurrent, but 10 days in herpes, HIV infected individuals. If it's valsiclovir, we give it 1 gram BD. Coming to the management lesions, same treatment where we give acyclovir 400 mg 3 times a day, or valsiclovir BD. Like I said, initially for 7 days. If it's recurrent, usually we give it for about 10 days. And when there is severe mucocutaneous infection, we prefer IV treatment with 5 mg per kg, 8 hourly, and we monitor for about 21 days. After the lesions begin to regress, we change over to oral therapy if warranted. Next slide, please. So when do we use acyclovir and foscarnet? Foscarnet is used in patients who are resistant, to acyclovir. So acyclovir, like I said, in a neonatal CNS disease has to be given 20 mg per kg, 3 times a day for 21 days. And if it is severe gingival stomatitis, 5 to 10 mg per kg per day, per dose, for about 14 days. So the adverse effects could be phlebitis, renal toxicity, nausea, vomiting. And usually acyclovir is our go-to drug. We would choose it unless otherwise, if not warranted or if resistant, then we switch to foscarnet, where we give 120 mg per kg per dose in 2 to 3 divided doses. But renal toxicity is more common and electrolyte abnormalities is more common. That is why we don't really prefer foscarnet. Next slide, please. So herpes zoster, extremely common again in our OPD, but in a patient with HIV, it can present with multiple dermatomes. It can present with extreme post-herpetic neuralgia and hemorrhagic bullae. It is caused by the varicella zoster virus or HHV type 3, and the course is also more prolonged. It requires a longer course of treatment, more risk of scarring and all. So we have to get them tested for HIV. Usually they come with a prodrome of pruritus or fever. Next slide, please. So this is how it presents. Can you see how extensive the lesions are? If the patient was immunocompetent, this sort of lesions would not have appeared. So because they're extensive, it involves multiple dermatomes. Some lesions, we can even see hemorrhagic bulla. And herpes zoster ophthalmicus, which involves the trigeminal nerve, that is more common. I'll just talk about this. Next slide. So it is extremely distinct. If we need, we can do a Zang smear or viral culture. Usually the treatment is acyclovir 800 mg 5 times a day, or valsiclovir 1 gram TID, or famciclovir 500 mg 3 times a day. Next slide. So how does ophthalmicus present? It usually presents with involvement of the eye sometimes. So we have to send it to an ophthalmologist for corneal involvement to rule it out. So that should be treated with systemic or topical antiherpetic medications as per the ophthalmologist advice. If there is visceral involvement, then we have to start them on IV therapy. Next slide, please. So in children living with HIV, for moderate disease, we give acyclovir 10 mg per kg per dose every 8 hours. In mild disease, we give 20 mg per dose every 6 hours for about 7 days. So acyclovir is the treatment of choice. In acyclovir resistant disease, we use foscarnet, and IV only in patients with severe immunosuppression. We have to remember this, that foscarnet only in acyclovir resistant and IV only if it's a severe disease. Otherwise, we stick to oral. Yeah, next slide, please. So molluscum contagiosum, again very common. It is caused by the molluscum contagiosum virus, which is a pox virus. spreads through skin to skin contact, especially during sexual activity, because there'll be a lot of trauma, and that friction could lead to genital molluscum contagiosum. So they usually present with shiny pearl-like papules with central umbilication. And usually they'll be more extensive when the CD4 count falls to less than 50. Next slide. Next slide, please. Yeah. So this is patient with extensive MC. So that is what I said. These are the close differential diagnosis that has to be seen in these people. In such patients should be cryptococcosis or even penicillosis, because of the distinct nodules. So not all of them you would look at it and say this is molluscum contagiosum. This is extremely hard to treat, and usually happens when the CD4 count falls to below 50. Next slide, please. So usually what we can prefer treatment is electrocautery with cryotherapy with liquid nitrogen. Sometimes we can, even if the lesions are small, we can do curettage or even electrocautery, but for such extensive lesions we prefer cryotherapy. Sometimes even topical creams such as podophyllum and trichloroacetic acid, tretinoin, phenol can be used. Cimetidine, oral cimetidine can be used if the lesion becomes itchy or extensive. Definitely ART needs to be initiated. Next slide, please. So oral hairy leukoplakia is very characteristic of HIV, like how we were talking about. It is associated with the Epstein-Barr virus, and it mostly occurs in people living with immunosuppression. So more than 25% of the people living with HIV developed oral hairy leukoplakia at some point in their life, but it is more common when the CD4 count falls to below 200, and it is one of the first signs of development of the acquired immunodeficiency syndrome. Next slide. So how does it present? Presents with white striations along the lateral margin of the tongue, can be shaggy in appearance and may contain several ridges, but usually asymptomatic and discovered during a routine clinical examination. Next slide. So this is how it presents. Can you see the striations, and can you see it only over the lateral area of the tongue? So this needs to be looked at by a ENT surgeon as well to decide the therapy. Treatment. Next slide. So how do we treat it? Usually liquid nitrogen or surgery can be one of the choices, or tretinoin can be applied, but not very well accepted when they use podophyllin or tretinoin. And diagnosis is confirmed if we see on electron microscopy, we see the Epstein-Barr virus, and we do it by scraping the lesion. Next slide. So the inflammatory conditions, now coming to them. So what is cirrhosis? It is increased dryness of the skin, and ichthyosis is a more severe form of this cirrhosis, where it is more prominent on the anterior locus, lower legs, because its skin tends to be very dry on that area. So we give thick greasy moisturizers, but mild topical steroids can be required if there is extensive dermatitis inflammation. And usually we advise moisturizing lotion right after bath, and to use a moisturizing soap, and to use lukewarm water before bath, for bathing. Next slide, please. So what is seborrheic dermatitis? It is a mild eruption which usually affects the scalp and the central areas of the face, and usually, like I said, central part of the chest, and particularly in individuals with a lot of chest hair. But it could also affect the axilla and the groin, because they are seborrheic lesions. And it is one of the most common inflammatory dermatosis. It presents with poorly defined, faint pink patches, and in the scalp we see thick greasy scales, but here we see waxy scales. So in children living with HIV, presents as erythematous scaly patches with an overlying greasy scale on the scalp. So presents with mild topical steroids, tar shampoos, and sometimes even we give a combination of a steroid with an imidazole like clotrimazole. Next slide. So cutaneous malignancies like Kaposi sarcoma, which are more common, and a non-Hodgkin's lymphoma, which we spoke about. Next slide. We already spoke about the Kaposi sarcoma. That is why we're speaking about the non-Hodgkin's lymphoma, where it is the prevalence is more about 4% more than the general population, and it is the most common type of cancer. Like not even Kaposi sarcoma. Kaposi sarcoma is characteristic, but this is the one which is more commonly reported. And high levels of lactate dehydrogenase and advanced systemic diseases in 80% of the cases are seen. And manifestation depends on the site involved, and it has a highly invasive, so extremely severe form of the disease. They will present with non-Hodgkin's lymphoma. So usually treatment is the chemotherapy with cyclophosphamide, hydroxydonorubicin, oncovin, prednisolone, along with the antiretroviral therapy. Next slide. So this is how non-Hodgkin's lymphoma presents. Could present with nodules. The cutaneous manifestations are less common. Usually we diagnose because of this visceral involvement. Next slide. So in male patients with HIV, usually the risk is 17 times more, and female it's 10 times. The prevalence about 38% in males and 16 in females. Next slide. So coming to the miscellaneous conditions which we could expect, drug reactions. Yes, very common. These drug reactions like maculopapular rash or even toxic epidermal necrolysis or Stevens-Johnson syndrome, when widespread, that is when we have to think about HIV. Yeah, next slide, please. So most reactions occur in the second week of therapy. Now, usually a lot of our patients come with drug reactions, but when severe and it's not responding to classical therapy, we definitely say, please get a retro done, because I mean, a HIV test done, because more often than not, they'll be positive if they're resistant. So these reactions occur in the second week of therapy, and are typically maculopapular or a morbilliform rash. And the use of systemic corticosteroids has substantially reduced the rate of drug reaction from trimethoprim sulfamethoxazole. That is where we used to see the most number of drug reactions. But because we are also using systemic corticosteroids, the incidence of drug reactions is less. But the other drug-induced reactions that we can see is urticarial reactions or erythroderma, fixed-up eruptions or erythema multiforme, and toxic epidermal necrolysis and Stevens-Johnson syndrome, like we said. Next slide, please. So these are the pruritic papillary eruptions, often misdiagnosed, undertreated, and it happens very common in developing countries, not in developed countries. And this is mainly because of the insect bite reactions that it happens, and usually presents with pruritic eruptions on the hands and the legs. Next slide, please. So prevalence is about 11 to 46%, and it can be the first marker of the HIV infection. It presents as chronic bilaterally symmetrical pruritic papules and sterile pustules on the trunk and the extremities. A differential diagnosis includes follicular and non-follicular pruritic eruptions, including scabies, insect bite, prurigo nodularis, and eczematous eruptions. So topical corticosteroids, emollients, and oral antihistamines are preferred. And when they're secondarily infected, that time we have to use antibiotics. So next, coming to the next thing, that is acute HIV exanthem and enanthem. So the frequency of the rash can be 50%, and they can be exanthematous or pityriasis rosea-like over the upper trunk and the proximal limbs, and may involve the palms and the soles. So they are associated with features like fever, malaise, myalgia, arthralgia, and pharyngitis, and an associated enanthem may be present. So what is this associated enanthem? It could be oral erythema or superficial eruptions, dysphagia or retrosternal pain due to oral and esophageal ulcerations will be the most common complaint. Or dysphagia could also happen due to esophageal candidiasis, which is more common in HIV patients. Next slide, please. Yeah, so this is, I think we have covered extensively about like the opportunistic infections which can occur of the skin and the mucous membrane in people living with HIV. Like I said, like I stressed upon it many times, we see these conditions, mostly we see common OPD conditions, but we have to keep in mind that if it is severe, not responding to treatment, and if it comes with an extensive form of the disease, we have to suspect HIV, especially if they have multiple partners. If they come with a other STD, then we have to get a HIV tested along with it. In men having sex with men, we have to do HIV if they come with any sort of lesions and they say that they have a history of unprotected intercourse. So these are my main takeaways. Thank you so much. If there are any questions, I would please let
Thank you
me.
so much, ma'am. Requesting participants to please unmute and ask questions. In case you have questions, you can now unmute. Mic access has been given to everyone. Any questions from the participants? Ma'am, I don't think there are any questions. Thank you so much for facilitating this important session.
Thank you so much. Thank you for the opportunity.
Thank you, ma'am. Ma'am, we'll quickly run the feedback form. Won't keep you waiting. We'll run the feedback form and later conclude the session.
Sure, done. Yeah.
Thank you. Thank you. Requesting all the participants to please fill in the feedback poll. There are 5 questions in all. Scroll through the questions, click on the answer of your choice, and please read the last question carefully. Requesting all the participants to please attend the feedback poll. Kiran sir, we can end the feedback poll now. Thank you to all the participants for patient listening. We'll conclude the session now.
Thank you.
Thank you, ma'am.